So imagine fall, fine Minnesota morning. You're getting ready to get to your practice, any suburb here in Minnesota, and you're looking at your schedule for the day, right? And you realize that you have a 6-year-old child coming to see you that day in your dental practice, okay? And you're looking at the intake form, you are looking at the medical history form, and you realize that the patient is there to see you because they need to be evaluated for oral cancer, okay? Now, your brain is working. It's like you take a double take on the history intake form. Why is a 6-year-old child here to see you? Right? I don't think if you go back, you are almost convinced that this child does not have any of the traditional risk factors that you would look for, that you have studied in oral pathology, right, back in dental school. But you have a very puzzled look. The child is there with a very concerned mother in the chair. So she sees the puzzled look in your face. She interjects immediately and says, our pediatrician wants us to come and see you because he was recently diagnosed with Fanconi anemia. And we want to make sure he does not have oral cancer. Now, your brain is working overtime. It's thinking, man, I don't know if I ever studied. I need to get back into the back room and open up an oral pathology book. Did Dr. Raj ever talk about this in dental school? I don't know. You're trying to figure out what's going on. So in the next few minutes, right, what I'm going to do is talk about Fanconi anemia and oral cancer risk in these patients, and how as oral healthcare providers, we as dentists, dental hygienists, dental therapists, play a significant role in their lives, okay? So this is what every patient who is visiting the dental office for the first time after a diagnosis of Fanconi anemia will bring with them. This is available through the Fanconi Anemia Research Foundation. They are available for everybody to get educated, and they are asked to take this because of the same experience that they're going to have. They are not alone. This is what every single patient, when they go back to their dentist for the first time, will experience. This puzzled look on the dentist's face, okay? So first, let's talk about Fanconi anemia. Fanconi anemia is, and I'm going to refer to that as FA moving forward, so I may go back and forth. So FA is a genetic disease, very rare genetic disease, where the patients have a defect in DNA repair. Okay? All the consequences because of how they can improperly repair their DNA. And the specific DNA damage that they cannot repair is called interstrand crosslinks. Okay? And because of that, they have very significant consequences, like bone marrow failure, birth defects, and high risk for cancer. Head and neck cancer specifically, and more specifically, oral cancer. FA patients have about a 700-fold increased risk for developing oral cancer, okay? And this is where we come in, okay? And they develop oral cancer at a much younger age than you would imagine for a non-FA population, okay? And it seems to progress pretty fast. And it looks now that the oral cancer in FA patients is one of the major causes of mortality in these patients. The oral cancer, there was no treatment, I'll come back to FA, in the beginning for these FA patients. Okay, there was no treatment. But now, thanks to a lot of work done by folks here at the University of Minnesota in the bone marrow transplant clinic, as well as worldwide, these patients can undergo hematopoietic stem cell transplant, bone marrow transplant, okay? And they live longer. They live longer, but the other flip side of that is that age, along with other consequences because of the transplant, like graft versus host disease, puts these patients at a really increased risk for cancer, like oral cancer. Okay? It seems to progress very quickly, and again, it's the younger population. So it is more of a cancer susceptibility disease now, is what we are understanding this to be. Okay. Treatment. The traditional treatments that we use for these patients, for a non-FA oral cancer patients, like chemotherapy and radiation therapy, cannot be used in these patients. The reason being, the chemotherapy, for example, kills the cancer cells by causing interstrand cross-link damage to their DNA. If you remember, these patients cannot repair their DNA. So not only the cancer cells, but even the normal cells. In a non-FA population, the normal cells can be repaired. But in these patients, they cannot repair their normal cells that are damaged by chemotherapy. So surgery is the mainstay of treatment for these patients. So this is where we come in. The way that we can save their lives, is to catch these conditions at a very early stage, right? Catch them at a very early stage. So the treatment can be minimal if they're doing surgery, and it's curative, right? And we also reduce the morbidity that goes with the treatment. Okay. So there are, I would say, frequent and regular visits to the dentist for their checkup and their oral exams are very critical for these patients. Right? So for example, here at University of Minnesota, every patient that comes in to the bone marrow transplant, and we are a big center for that, they come and see us in the dental school. They come and see Dr. Shanti Kaimal. Along with me, we see all these patients. They make a visit, and we do an oral exam for them and an oral cancer screening for them. Okay? And if we find anything, we refer them over to oral surgery, and Dr. Abgard will do a biopsy for a lot of these patients. Now, the problem is some of these patients will need to have multiple biopsies because there could be multiple lesions. In FA patients, similar to the non-FA population, the progression goes through, in many cases, goes through a well-defined white and red lesion stage. So we want to make sure we catch them. The other thing that I would like to say is that we need to have a very low threshold for these patients. For a non-FA population, we may not do a biopsy on that lesion, but for an FA population, we want to make sure we get that biopsy. So sometimes these patients have to undergo multiple biopsies in the same visit, or we'll have to have frequent biopsies, which can get tedious and can get really impractical in some situations. So there is a lot of work that is being done on trying to come up with a non-invasive way of trying to diagnose malignant lesions, or if that particular lesion is cancerous or not. There is a group out in Germany, and I'm showing you their work, who has been working with FA population for almost 15 to 16 years. They've done a lot of work. They have a huge database. And in fact, most of our FA population will know about these investigators. And what they have shown very successfully in their recent publication in Cancer Cytopathology, that if you can do a brush-based cytology sampling, and they can recognize in very great accuracy cancerous cells, okay, and precancerous cells. In fact, the group has shown that by using this methodology, if you get a negative result, right, they can very confidently say that it is not high-grade dysplasia or high-grade cancerous lesion, or if it is invasive cancer. So then what happens is once you get a positive result, you can then refer the patient over for a biopsy. This would reduce the burden in these patients of doing so many biopsies on them frequently or in one sitting, because it can get very tedious for them. Okay? So now a lot more work, including us. We are doing a lot of work with several worldwide, trying to come up with other more efficient ways to non-invasively diagnose and help this patient population out. Another study that we have been doing, this is led by Dr. Rachel Upgard here in our dental school, and I was part of that, and Dr. Boyan was part of that too, where we have shown that patients with oral premalignant lesions, right, also have, this is about 85 patients that we have in our database. Also, if they develop an oral premalignancy, they also are at a high risk for developing not only oral cancer, but also non-oral malignancies. This further signifies and underlines why these patients should have more frequent oral exams and oral cancer screenings, because you can not only helpful for their oral cancer, but also for malignancy in general. So I want to end my talk today by talking about the significance of what as oral healthcare providers, all of us can do in helping these patients out. And I want to challenge all of us that every time, not only an FA patient, but even a non-FA patient, when they come to your clinic, in your chair, you will do an oral cancer screening. Even though you have just seen the patient maybe 5 minutes or even earlier that morning, every single visit, you will never know what that impact will be on those patients. Thank you.